interviews, so we're just gonna take her lead. But that's Mackenzie, and she's with us too. So today, real quick, what we'll be doing, we're starting with what is the procedure. We'll run through some steps, some key anatomy. We're gonna highlight the goals of the procedure, and then we'll talk to y'all about the risks.
So what exactly is the ACDF procedure? So basically, it's a surgical of the cervical spine to relieve pressure on the back of the neck. Sorry, I'm going to be touching myself because that's kind of how I learned the surgery, or if anybody wants to be my patient. So ACDF stands for anterior, which is the approach from the front of the spine. Cervical.
This may help.
Yes, okay. Cervical dissectomy, which is the removing of the disc that's compressing the bone spurs, and then fusion is the stabilization to like fuse the bones together. And then we can go to the next thing. Okay, why is ACDF done? So basically it's done for herniated cervical disc, degenerative disc disease, cervical spine stenosis, arthritis in the neck, nerve pain down the arm, and spinal cord compression. So next, we're going to go into the steps of ACDF. So the first approach, of course, you have to lay your patient down, but you have to lay them on the front. So you have to lay them like front and make sure that their neck is, open like this. And you have to make sure the neck is kind of slightly like this, like ascended like this.
Did that surprise you guys that it's through the front?
To me, yes.
Yeah.
Because when I was thinking of spine surgery, I thought they were going to go through here.
It freaks people out when you talk cervical. I mean, you literally make an incision, you just take your esophagus and pull it to the side, and then you're looking at the front of the cervical spine. But like when you hear that, you're like, oh,
That's what anterior stands for.
Yes,
Right.
the front. So next slide. So they'll make a small incision where the crease, so like if you did a double chin, like, so they would do a crease of the neck, so like kind of hidden, so it's not like crazy. But they're gonna just like move the muscles apart to get to the spine. And then they'll use an x-ray to confirm like this is where they're like having pain. Because like most of the time it's like nerve pain, so like if your arm went numb, you'd be like, oh my gosh, gotta go get ACDF procedure. But maybe not all the time. Okay, so next they're gonna remove the disc between the two vertebrae, and if there's any loose fragments, they'll kind of clear it out to make sure like there's not like, you don't want like a loose bone, like at the same time like if you had a chipped tooth, you don't really want like that rest of that chipped tooth, so you could go to the dentist to like remove it all, if that makes sense. Next they're gonna make sure like it's kind of smooth, they'll smooth down the bone spurs before they kind of like relieve the pressure. So when they relieve the pressure, it's relieving that nerve root, that arm symptoms that you're getting, that's numbing, or like the spinal cord if you're like unbalanced or like you're kind of having some pain in the back of your neck. That's kind of basically what's happening. And you can go to the next. Next, we're gonna go, so Holly will get into what exactly the spacer is going to be, but they'll apply a spacer because you can't just have like space in between when you take out this vertebrae, because like your head might fall off, not really, but like, but it kind of remains the height. Because like if they were just like put it down, you would like, as Izzy's story, they like helped her spine, she grew. But if they were like to put like your thing like this, you would shrink, but not a lot of people want to shrink. But it helps with like the alignment of the spine. Next. So as I said before, these are placed, the spot, like the disc is placed with screws and everything, and this will apply for the bone to be secure and stabilized. Then next. And then of course they're gonna either do like a suture or they're gonna apply some glue to make sure that incision is closed. And then depending on like what happens post-op, they might apply a neck brace or pain medication to relieve any pain. That kind of helps stabilize this and make sure that you're not feeling any pain post-surgery. And then I'm going to hand it off to Holly.
Can we jump in? I know you probably have stuff to say. Great job first.
No, I think she's doing great.
That was awesome. I just want to add stuff to it. You got any comments you want to make first?
I mean, no. I mean, I think you're doing a great job for. I don't know how long you guys had to put this together.
Like a week.
Yeah. You're doing a great job. I think. I mean, obviously, there's a lot more to it than that. But,
Yes.
Putting the bone in, there's different types of spacers you can put in the neck. There's bone, peak, titanium, and that's one of the components that surgeon preference, and then the plate, we can get into that a little later, but the plate, you put it on over top to stabilize that bone. And when you said like you take the disc space out and then your head shrinks, not in reality, it's really to cause fusion. So they try to restore the height in that space that's normal in the cervical spine versus, you can't let it just drop, obviously, but so that's why they do it, but to restore the height. And it takes pressure off the nerve roots in the back, so.
And I was just going to add to it because it's going to be consistent with all of your presentations. There's a lot of consistency whether you're doing surgery up here or surgery down here in the lower spine, right? So a lot of these disc herniations and things that happen, they end up having a neurologic effect, right? And so that's kind of what you're talking about. So it ends up pushing on a nerve root or on your spinal cord depending on where it is. And then your spine, like the whole purpose of your spine is to control the entire body. Like your brain actually goes right down the spine, so all your sensory, everything, like if I touch your arm right now, you'll feel it. And the reason you feel it is because there's a nerve root that comes out of your cervical spine, it runs down here, and it tells your brain what just happened, right? So all that stuff controls your entire body. If you have a neurologic problem, you have to, what they call decompress the nerve root, right? Take that pressure off of it, and most times when we're going in there to do that, we destabilize the spine, and so we have to reconstruct it. Right, and so that's what we did in the front. We took the disc out. We're just trying to get there so we get off the nerve root, but then we left this big space, and so that's when we start reconstructing. Ultimately, what you're trying to do is get a fusion in a lot of these, except for the arthroplasty group. So you guys will tell us that. And I think of this like a cast on your arm, right? So if you broke your arm, some people get plates and screws. Some people just get a cast. Some of you probably had that happen. We're trying to grow bone. Right, and there's principles for growing bone. It is you have to be stable, and stable happens with a cast, or it happens with a plate and screws and inner body. We're building an internal cast, and we're holding the body still so that natural bone healing can happen. After all that bone grows, then you don't even need the hardware. We'll keep it in there because it doesn't make sense to go get it, after the fact, 12, 18 months later. But we've fused and we've taken care of that problem and reconstructed the spine. So great job, awesome. Yep. Go ahead, pass it over.
So you actually did a great job of describing the anatomy affected, so thank you for that. Better than what I could do. But one thing to note, it is really important since you are laying like facing up, when they cut through the skin and the muscle, your carotid artery is right there, so it's really important that the doctors be really careful before they even get to the actual bone to not mess with that. And they do have to move the esophagus out the way. Yeah. Okay. Sorry. No, that's good. Okay, so some goals for the procedure. As we said, obviously the nerve compression is a huge pain relief. Neck pain, as we said, stability. Once that's in there, it'll give you a lot better spine alignment every day, and then obviously your range of motion in the neck is improved.
So during the ACDF procedure, there are multiple implants and hardware used to stabilize the spine. So Megan was talking about this earlier, but the inner body spacer or cage is placed where the damaged disc was removed, so you can see that right there. And this inner body spacer is filled with bone graft, and this bone graft can come from the own patient's pelvis, or it can come from a donor, or it can be artificially or synthetically made in the lab. And then, so what this bone graft does, it allows the vertebrae to fuse together over time, and then the anterior cervical plate is placed on in front of the vertebrae to provide additional stability and but allow the vertebrae to heal during fusion. And then the success rate of ACDF surgery is around 85 to 95%. And then these common, usually temporary risk is difficulty swallowing, hoarseness, neck soreness, and/or stiffness, mild throat pain, and nerve irritation. And then you got the less common but more severe risks like failure of fusion, hardware problems, nerve or spinal cord injury, adjacent segment degeneration, no central relief, infection, blood clots, bleeding or hematoma, and then injury to esophagus or trachea.
So obviously, as we said, this has been proven to be a really high effective procedure, really good success rates, and it's always going to be improving as more science and technology improves, like what we have here today. It is minimally invasive, and it still remains a gold standard for treating spine pain and everything else.
Thank you.
Y'all hang out here for a second. Let's just get a little conversation.